Ibrutinib is a novel BTK inhibitor. It's an oral agent that inhibits a key signaling pathway in the B-cell receptor complex of Bruton's tyrosine kinase. And it's been evaluated in multiple different places for diffuse large B-cell lymphoma. And by places, I mean in disease settings, first line, relapse, different contexts. Unfortunately, the Phoenix trial, as a general overall study, was a negative trial showing that the addition of R-CHOP plus ibrutinib was not better than R-CHOP plus placebo. However, when we dug into subsets, when we looked at specific genetic subsets as well as in younger patients, we saw that there was a significant improvement in those unplanned analyses, implying that perhaps there are patients who derive significant benefit from ibrutinib. At my center at MD Anderson in Houston, Texas, we've recently published the SMART START clinical trial, which was evaluating the combination of ibrutinib and lenalidomide and rituximab, a novel 3-drug targeted therapy combination, as an initial treatment for newly diagnosed patients for 2 cycles. And there, ibrutinib, lenalidomide, and Rituxan had an overall response rate of 86%. And when it was added to chemotherapy, and 36% of those were complete responders prior to a drop of chemo, which is something we'd not yet seen before, of targeted treatments prior to chemotherapy. When we added it to chemo, we had a 100% response rate. And at 2 years, thankfully, more than 90% of our patients have not yet progressed, and more than 90+% are still alive. So ibrutinib, with the right partner, is a viable agent for diffuse large B-cell lymphoma, even though by itself added to R-CHOP didn't work. If you added things like lenalidomide, it unlocks the true power of that drug. Now, there are an avalanche of new BTK inhibitors that have theoretical advantages over ibrutinib, both with a more selective profile, hitting less off-target kinases, as well as more potency and durability in the inhibition of BTK. And many of these have shown great promise in other diseases where BTK has become a standard of care, including CLL and mantle cell lymphoma. For large B-cell lymphoma, we're awaiting some large randomized trials evaluating R-CHOP plus other BTK inhibitors, including acalabrutinib. And in the relapse space, some of these BTK inhibitors, such as pirtobrutinib and zanubrutinib, have shown early promise. So BTK inhibitors haven't yet changed standard of care in large cell, but I'd say stay tuned for what's coming for these upcoming studies.